Hello and welcome to today's webinar, Building a Sustainable Community Health Worker and Promotore Workforce, Lessons for California, made possible with support from the California Healthcare Foundation. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a moderated question and answer session following today's presentations. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on chcs.org. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I'll now turn the webinar over to Kathy Moses, Senior Fellow at the Center for Healthcare Strategies. And Kathy, you're muted.
Hi, good morning, everyone in California, and welcome to those of you also on other coasts with later times today, 1 o'clock instead of 10 o'clock. So happy to have you all here today to join us for this webinar that will take some time to dive down into considerations around recognizing the professional recognition professional recognition of the community health worker and Promotore workforce. Next slide. I'd like to start just by giving a brief overview of the agenda. We'll start with welcome and introductions, and then a quick video as part of our introductory welcome statements. We'll then spend some time talking about the report, recently released report, Training and Supporting Community Health Workers and Promotores in California. And then we have two individuals joining us for reactions from the field, and then we'll open for Q&A. Again, my name is Kathy Moses. I'm a senior fellow here at the Center for Healthcare Strategies. I'm joined today by Carlina Hansen, who's a senior program officer at the California Healthcare Foundation and the project officer for this work, as well as Heidi Bayferuz and Joe Calderon. Heidi is the medical director of Housing for Health at the LA County Department of Health Services and has a long career in improving and furthering the work of community health workers. And Joe Calderon is a lead community health worker at the Transitions Clinic Network, a community worker himself, and has just a lot of passion and advocacy for the workforce. So thank you all for joining us today. Just a little bit about the Center for Healthcare Strategies. For those of you that don't know us, we're a nonprofit policy center dedicated to improving the health of low-income Americans. We were started with a grant from the Robert Wood Johnson Foundation in 1995 and serve people from across the country, working primarily with Medicaid, health plans, providers, and their partners as well. This project falls within our portfolio for integrating services for people with complex needs. And now I'd like to turn it over to Carlina Hansen for a few welcoming remarks.
Greetings, everybody. As Kathy said, my name is Carlina Hansen, and I'm a Senior Program Officer with the California Healthcare Foundation. I am very grateful to be here with you and our fabulous panelists today to talk about community health workers and promotores. I think many of you are familiar with the foundation, but just briefly, California Healthcare Foundation is a healthcare philanthropy based out of Oakland and Sacramento. We are dedicated to advancing meaningful, measurable improvements in the way the healthcare delivery system provides care to the people of California, particularly those with low incomes and those whose needs are not well served by the status quo. Next slide, please. So last year, a group of healthcare leaders from around the state came together to examine what needed to happen in California to meet the state's future health workforce needs. This group, called the California Future Health Workforce Commission, came up with 10 top recommendations. And among those was a recommendation to scale the community health worker and Promotore workforce in California. The Commission's reasons for focusing on community health workers and promotores are very much aligned with why the California Healthcare Foundation has chosen to engage in this work. As most of us know, California faces extreme challenges with primary care workforce shortages, particularly in certain regions of the state. Simultaneously, communities of color and low-income communities bear a disproportionate burden when it comes to health, social, and economic disparities. And COVID has unfortunately exacerbated and highlighted this. Simultaneously, we know that our healthcare systems are not always well equipped to reach these communities. And this is where community health workers and promotores often come into the picture. Next slide, please. Next slide, please. To amplify the engagement with this workforce, the Commission recommended two primary things. Prior to COVID, the Foundation intended to support the certification of training programs in California. However, given the demands that are currently being placed on most of our stakeholders, we're adjusting our focus to support the integration of community health workers and promotores into Medi-Cal with a focus on CalAIM. Next slide. All of this context acted as the impetus for engaging Center for Healthcare Strategies to help us understand the landscape for community health workers and promotores and the lessons that California can learn, both from what is already happening in the state and from what's going on around the country. And I think many of you who are on the line today were featured in that report. So this report will help for California to advance this important workforce. I want to thank and her colleagues at Center for Healthcare Strategies for all their work pulling it together. And finally, we are often so focused on talking about health disparities that we forget to tell the story of the resilience and strength of communities. Community health workers and promotores are a huge example of that. Though they could benefit from a policy change to strengthen their capacity, they are definitely not waiting for one. They are on the ground doing the work when their communities need them most. So I thought it'd be nice to kick us off with this short video that really exemplifies that. Emma, if you could pull that up.
Today, we're hosting a mobile clinic, a community clinic at Anaheim High School. This school is located in one of the most impacted areas in Orange County. I live in this community. This is my home. This is my high school that I graduated from, that my family, we all went to school here. Sometimes families are maybe undocumented, right? And they feel like if they get any kind of help from the county or the government, then they're gonna have like records of them or something, and it's gonna affect them. So we tell them, this is for anybody, this is free.
So it's testing with equity big time. It's also what do you do after you test positive. Now you need to isolate, but you don't have food. So we came up with this strategy also in which we deliver food to their homes. We got in a partnership with a local grocery store, and they prepare a basket that we give to them. So people, we are telling people, we have your back. We will give you food. Just stay home.
Hello? Hola, sí, dígame, mire, señora Socorro, usted me dejó aquí un número de teléfono.
So what we do as part of the call center, it's usually we get a feel of what their needs are. They call in and they usually want a testing site. Once they ask me if there's a testing site, and then later on they start telling me the story, I get a feel of what their needs really are. So like she wanted a testing site, the lady that I just did, but she told me, what else can you help me with, because I haven't paid my rent in the past month. When you see your neighbor struggling, when you see someone struggling and that you can help out, you have to. It's a must.
We don't want to just do things so people can be better today, because at the end of the day, what has been happening for these 27 years created the vulnerability for COVID. So we are not just COVID, today. We are saying COVID today and what tomorrow and what the day after tomorrow. And I think that's what is making a difference, that we are not waiting for the vaccine to recover. We have started recovering already.
Great, next slide. Thanks so much for sharing that video, Carlina. It's really always so helpful to have the voices included in these kinds of webinars, and hopefully we'll have some of those voices in our Q&A, and certainly we do in our reactor panel, but I think it's really helpful to see things put into action and what life is like beyond a report. With that, I'm going to talk about the report. So as Carlina mentioned, we put together this report recently released, I believe in August, and we will, for those of you who have not seen it, send it out via the chat feature, send out the link via the chat feature. But the project involved a variety of components, including scanning practices across the country, what's happening in other states outside of California around training and certification of community health workers. We also conducted interviews with experts in the field, mostly in California, some national experts as well, who are involved in training and certification, and our employers, health plans, a variety of individuals, all interested in enhancing the role of community health workers and promotores in California. And then lastly, through compiling those two, identifying training and certification recognitions, really around this theme of how to enhance professional recognition of community health workers and promotores. So it could be through training, it could be through certification, it could be through providing education to employers, it could be through building career ladders. Really the overall theme is how training and certification can support enhancing professional recognition. Next slide, please. So the first thing we did was look into some of the current community health worker and promotora training approaches in California. This is, of course, not an exhaustive list, but includes some of the major trainers involved to date in training community health workers and promotores. I won't read all of this, but just want to point out there's a variety of models. So for example, the Worker Education and Resource Center has an apprenticeship model, which builds on the needs of employers. The City College of San Francisco has a community health worker certificate program, and is also, I should note, the oldest community college community health worker training program in the country. Charles Drew University has what they call a CITW Academy, and it not only trains community health workers and promotores, but places them in sites around the city, and though others do as well, has a clear focus on establishing a career ladder structure for their graduates. And also Loma Linda has a training program focused on building the capacity of community health workers and promotores to operate explicitly within the healthcare system. Training includes work in clinics, in schools, and also includes continuing education. So as you'll see, these training programs, and we will differentiate between training and certification, are some of the highlights in California. Next slide. We also looked at some of the other approaches across other states that have a strong community health worker presence in their state. Massachusetts being one of those states. And one of the things I wanted to highlight here is who's doing the training. So in Massachusetts, it's actually the Department of Public Health, as well as the last one, Washington State, is the Department of Public Health. There they are, in Massachusetts, identifying certified training sites or certifying training sites, and allowing the participants to either go down a training track or an experience track. Training track obviously has the education component as well as experience, and the experience is for those who may just need to get some of the hands-on experience. In Minnesota, a formal training is offered across 7 community colleges. And unique to Minnesota is that individuals who receive training from one of these 7 community colleges then can be certified, and employers then are able to bill Medicaid for their services. Michigan's approach is highly driven by their Community Health Worker Alliance. And so they have established a certification training curriculum that is commonly used across the state, but there's not a state requirement to use that training. Texas also has a very state-driven approach with the Department of State Health Services certifying, similar to Massachusetts and Washington's Department of Public Health. They also have a certification and training program for the CHW instructors as well as continuing education. And last but not least is Washington State. They offer a free continuing education for community health workers and promotores that consists of health-specific models such as breast health, cancer screening, family planning, and HIV. And we'll talk about that a little bit more later in terms of the importance of or balance between kind of core requirement, core curriculum, and specialty curriculum. So next slide, please. So some of the lessons that we learned in conducting our scan and in talking to folks across the country and in California include balancing training and experience. And so really the thought here is that any effort to support training programs should consider the balance between requiring in-class trainings as well as experience on the job, because many of the successful training programs already in place in California have extensive practical elements where community health workers and promotores can learn on the job. However, no amount of role playing or classroom work can adequately expose a candidate to the types of situations in which the community health workers and promotores find themselves. And so internships, apprenticeships, extended on the job experiences allow them to find the area that they're most passionate about and gain that experience as well. Accessibility for all. You'll hear part of this theme in a variety of slides throughout this presentation and throughout our reactors comments as well. Here in the context of training, accessibility for all is about understanding that community health workers and promotores are from the communities that they serve. They may or may not have the resources to embark onto a training program, a fee-based training program. And so it is important to ensure that members of the community are not excluded in an unintended fashion. So making sure that training opportunities come in all different shapes and sizes and prices and locations is very important to make them accessible to the very individuals who are best suited to fill those roles. Next is training employers. So in California, the community health workers and promotores have been around and present. I think there's a growing recognition and interest in tapping into this workforce, but it may be that employers don't always have the experience with the workforce. And so a key lesson is also not just providing training for the community health workers and promotores themselves, but also helping employers understand their strengths, their capacity, how they fit into a care team, and being able to, again, best leverage the resource that they are beginning to use. So, and the last one, sorry, is ensure involvement of people with shared life experiences. Again, you'll probably hear a little bit more about this from Joe during his comments, but it's important to make sure that individuals who have valuable lived experience can often encounter barriers to employment as a community health worker. And so by taking down those barriers, identifying ways that, again, there's not a barrier to securing financial aid or high fees for the training, that policies around training are careful to take this into consideration in order to bring the right folks to the table for training and participating in the workforce. So next slide. The next thing we want to spend a little time talking about is certification. And just wanted to take a moment to say that before talking about the state approaches, that there's often a kind of like a formal or informal thoughts around certification. I think we tend to go right to a formal certification process and walking away with a piece of paper that someone then can use to show that they've attained these skills. But also, and that is what we're going to talk about on this slide, but there's also kind of the informal recognition around having a career path where there's, again, recognition of a growing path in terms of experience and oversight and being able to share knowledge that one's learned throughout the entire time that they've been a community health worker and perhaps as a manager or as other opportunities arise. So thinking broadly about what enhancing their role looks like can be more than a certification project or certification program. Massachusetts, I just want to kind of talk through these just at a high level. Massachusetts and Minnesota both have a formal certification program, Massachusetts being voluntary, both being voluntary, but Minnesota, as I mentioned earlier, is based on a certified training program. And so an individual who training from the certified training program then enables the employer to be able to bill Medicaid. And Minnesota is the first state that is using their certification in that way. South Carolina leverages a community health worker credentialing council to promote their core competencies and training. A credentialing council to support their core competencies and training. Texas has the requirement that a prospective community health worker or promotora must complete a state certified training or have a sufficient work experience that is documented by their employer. To me, this one, I just want to pause, is interesting. The second piece, the sufficient work experience, was intended or initiated in terms of trying to acknowledge those who should be grandfathered in, don't need the necessarily paper training and certification, but have been working as community health workers and promotores for years. And so wanted to acknowledge that piece in terms of being able to acknowledge or grandfather in existing experience. And last but not least is Washington State. And though they do have an established training, they explicitly do not have and decided not to have a certification program that directly certifies individuals. Next slide, please. So a few takeaways here are around, there we go, just in general, enhancing professional recognition. We've talked about nothing about us without us. Build or buy is really the notion of if this recognition program, be it certification or training, is something that is led by the state, or if it is led by another organization, such as a community health worker association, or an MCO, or another organization that is doing that work. And so that is the build or buy consideration. Another is learning from other states, but tailoring to specific state needs. And this is in reference to some degree of Carlena's earlier comments about the California Future Health Workforce Commission. You know, was really interesting interviewing some folks who were on the commission in terms of understanding specifically where California is in this point in time and where they intend to go. It's also very helpful to understand other states' stories and their paths to inform that, but ultimately, you know, states need to tailor what policies and decisions they make based on their current state infrastructure, where they're going, and other considerations along those lines. Last but not least is define the workforce broadly, which allows, again, folks from a variety of experiences to participate in recognition programs. Next slide. This next slide is just an acknowledgement that as we were writing this paper, something called coronavirus hit and became the thing that everybody was talking about and thinking about and working around. And so we thought it would be remiss to finalize this paper without acknowledging that, you know, what we were beginning to learn at the beginning of COVID-19 around how community health workers and promotores can engage in the virus. So one, of course, is the opportunity to lead the work or participate the work to contain virus spread, given the roles that they have in helping individuals find testing, I mean, exactly what's in the video, find testing resources, and do some of the education around infection control. And so some of those activities are just in the everyday experience of the community health worker. Second is navigating the longer term impacts of the outbreak, such as homelessness, and referring individuals to other community-based organizations, helping them get the resources they need. Again, I was really thinking about this slide during the video when the community health worker said, okay, or the person on the phone said, now what can you help me with? So I think that being able to see the bigger picture and not just the immediate effects of COVID and the infection are important. Third, expanding their existing reach into vulnerable communities by using telehealth. As many of you on the phone know, telehealth has grown exponentially due to the virus, and we have seen community health workers pivoting their work so that they can continue that close relationship that they have with folks, but still in a safe manner for themselves. And so being willing to show up and learn new software and how to do their work in another way is definitely one of the opportunities that have come out of the COVID response. Next slide. And next slide after that. So the next few slides are specific considerations for the state in terms of policy going forward and opportunities for enhancing community health workers and promotores' experience in the state. So first and foremost is including community health workers and promotores in the policy development process. This will not only strengthen the training and certification efforts in and of themselves with their knowledge, but it also ensures that they have a voice and are included in the decision-making process, which is very valuable. Next slide, please. Next is to revisit the recommendation from the California Future Health Workforce Commission report in light of COVID-19, understanding, and this reflects on the previous slide, what the opportunities are. It's a different world with, since the virus has, or the pandemic has hit. And so understanding roles and understanding how quickly adapting any kind of training or certification requirements would be a hindrance to the work going forward of these recommendations. Next slide. This one is, I'm sorry, I didn't talk about this earlier. The CDC has developed a policy evidence assessment report and on community health workers, and the pair, as it's called, there are multiple pairs on different topics. And so the CDC pair report on community health workers is about evidence, evidence around what works for community health workers, what as far as policies and programs. So this is a really interesting report to consider. I've listed the 8 recommendations out of the report that were scored as best in terms of having the most evidence to ensure positive, successful outcomes around community health workers. And there were also, you know, different degrees of best under that, but based on the CDC evaluation of multiple resources, this report shows some of the things that we've talked about in terms of certification and using team-based care, providing Medicaid payment for CHW and P services. So again, a very interesting report to consider in coordination with the Future Health Workforce recommendations. Next slide, please. So this recommendation is around the extended timeline that exists about a year, and hopefully so, for the extension of CalAIM in the Medi-Cal program. And so the recommendation is specifically to further explore integrating community health workers and promotores in the Medicaid program, both by exploring lessons from care management programs that have already begun and that are a part of the Medi-Cal landscape already, such as whole person care and health homes, learning from their role or their use of or integration of community health workers into those programs, and how that work can be extended or expanded in the next wave of policy programs in California under CalAIM. So given this approximate year or so, hopefully, that exists between now and the implementation of the CalAIM waiver, to think about ways to incorporate the community health worker and promotor workforce into that vision as well. Specifically, enhanced care management and in lieu of services are 2 areas that are ripe and envision, envision the role of community health workers and can also be an important consideration given state budget constraints that are arising as a result of COVID as well. Next slide. And so lastly, to seek balance while developing policies to strengthen the workforce through training and certification. And so this was a clear message, again, from many of our interviews and conversations around the importance and the value that comes out of standardizing training and certification, and creates a level playing field for community health workers, for employers, for training programs, but also in that balance to also take care not to impede the workforce at what they do best or exclude those who lack the resources to participate in formal training. And so that balance is where I'd like to leave you today, and turn it to Heidi and Joe, who will be sharing some reactions from the field.
Hi, good morning, everyone. It's a pleasure to be here with you. And I was asked to sum up all of my thoughts in 5 minutes, which is an impossible task, but I tried to distill to some of the lessons that I've learned from having walked with community health workers for going on 30 years now. Next slide. So one of the things when I do my consulting with either community-based organizations or Medicaid care organizations or departments of public health, community health clinics about integrating community health workers into their workforce, the question often comes around return on investment. How do we prove that there is value added from community health worker addition to our teams? And one of the things I want to tell you is, you know, even though we know to balance the moral imperative with fiscal pragmatism in our work, that if you worry too much about the ROI, you don't get very far. And I want to help us elevate the conversation that community health workers shouldn't be held to a different standard because we don't prove ROI for doctors or nurses or social workers. We understand that they are critical members of a healthcare team or a healthcare system, and we should view community health workers as such because they are critical assets to our healthcare infrastructure and our social infrastructure, and they're bringing unique qualities and qualifications that nobody else has, and really are providing distinct services that no one else is. And so it's a conversation that I'd like us to move toward because we only hold people that we're not sure about or don't have history with to the same level of scrutiny. And I'm not sure that that's what we want to do because we want to measure the efficacy of a team that includes this community-based social justice warrior as an important part of the solution to health disparities in this country. Next slide. The other thing I would say is that today, more than ever, the funding options for community health workers are plentiful. It doesn't mean it's easy. It doesn't mean that you don't have to think outside the box or think about how to cobble pieces of funding together. But as the CHCS document highlights, there are so many different ways now compared to 30 years ago when I started doing this work, where we can find sustainable funding source, not just hopping from one grant to another at the whim of the funder to pay for our community health worker interventions. CalAIM in California is particularly exciting. I wanted to just touch briefly on the two possible mechanisms. There's the enhanced care management, and as you know, the idea is that whole person care and health homes, everything is going to be morphed into CalAIM, a Medicaid sort of per member per month payment to allow for innovative enhanced care management of high risk or high acuity individuals, but also to help encourage our healthcare system to start doing more upstream work to address those social determinants of health that we know are critical. So within the enhanced care management platform, we don't know yet whether it's going to be an additional PM payment on top of your usual capitated rate, or whether it will be built into your whole PM, but it's essentially money, probably in that area of about $300 per member per month, to basically create these enhanced care management teams to take care of like the top 10% of your high acuity clients who have Medicaid in your panel. It's up to the service provider how they compose that team. And so I encourage everyone to think about the addition of CHWs into the team, but it needs to be a coordinated approach with everyone working with each other to make that difference. What remains unclear is what will be the reporting requirements. Will it be a certain number of care plans that have to be delivered, a certain number of services that have to be delivered? What are the quality metrics? Those things are still being sorted out by the MCOs, but that is definitely an opportunity. Also, in lieu of services, this is more optional at this point. So basically, the MCOs are being given an incentive to get additional funding to innovate. And the state has provided 11 different ideas as examples, and the MCOs can come up with programming to show benefit. So this could be around paying for housing navigators or paying for transitions of care from high-risk settings, really addressing some of those upstream social determinants of health. Right now, it's up to the health plans to decide whether or not they want to participate in lieu of service, as well as what services to offer. But the hope is that if enough MCOs sign on, take this funding, do some work where I think CHWs have a huge role to play, and we show benefit, that maybe it will become standard of care, so that things like housing navigation or work in the community around addiction, or work around transfer from jail or other institutionalized settings into the community, we can start thinking about some of those issues. There's still a lot to be decided. As you know, CalAIM was supposed to start this year, but given COVID, there's probably going to be a year extension for the MCOs to figure this all out. So the thought is maybe this is going to start sometime in January of 2020. And so whole person care and health homes are probably going to be extended out. So it gives us more time to plan, but also to advocate either as MCOs or those sort of community-based service providers, community-based organizations, community health worker networks, to really advocate for the MCOs to participate fully in this and to add CHWs as possible solutions to many of the upstream and downstream problems. Next slide. So you probably do have a link to this, but when you read the document, what I'm so excited about is that so many of the things that are delineated scream CHWs to me. And what a great opportunity for us to take advantage of this and really start moving the needle in terms of the health and well-being of our vulnerable communities. Next slide. So just briefly, some of the keys to implementation success, because oftentimes, you know, it's not necessarily the technology of the CHW, which I think is fabulous, but how do you implement it successfully? And I think some things that I've learned are to really clearly define the roles and responsibilities of the CHWs, not necessarily because they don't know what they need to do, but that the system in which they're being integrated doesn't know who they are and what they're capable of. And so by clear definition of who they are, what are their roles and responsibilities, how do they fit into the broader matrix, and how are one person interdependent on another to achieve certain aims is really critical to really think through and make sure that you have buy-in on. I think also when you're thinking about your plan, to really think about upstream, midstream, downstream. So what I mean by that is Downstream may be where you're integrating a community health worker into your ECM team and you're working on reduction of acute care utilization. And so they're enhancing the ability of your nurse care manager to do home-based visits, transitions of care, adherence interventions, et cetera. Also want to encourage us to think upstream. If we know that the root of so many problems, for instance, is marginalization, either based on your social or your fiscal capital, how can community health workers help change that? How do we advocate for more benefits? How do we advocate for dignified and safe housing? How do we advocate for the type of access that everyone needs, regardless of their sexual preference, their creed, their country of origin, so that they can really take advantage of the technologies that are available in today's world? I also feel like understanding where community health workers fit into an organizational chart is critical, and that we don't necessarily think of them as getting less than in terms of their access to tools and technologies that we make available to everyone else. I often get very frustrated when I'm doing consulting and the thought is, well, CHWs should only have read-only access in the electronic medical record. And my statement is CHWs should not only be able to read, but to edit and contribute to care plans and document so that they really do become a member of the healthcare continuum and the healthcare team. And I think the other thing is recognizing that CHWs are set up for failure if you don't figure out how they can access and utilize other members of a team or how other team members can use them. We should never try to figure out what is it specifically that a CHW did that made a difference. It's how did the team enhanced by the CHW make a difference? And so make sure that when you're doing your evaluation plans, you're looking at that. The other statement is that we often so focus on the training of the CHWs, we forget that, in my view, more importance is orientation, buy-in, and training of the existing staff, all the way from the CEO to the frontline workers, need to be trained on how to think differently and how to incorporate the CHW lens and activities into their realm of understanding and into their work. And finally, I'm going to say that it is not enough to just say that whoever already has 50 people to supervise can also supervise the CHWs. They need specialized attention. They need clinical supervision and programmatic supervision. And if you invest in CHWs and helping develop them as a workforce, you will see huge benefits in the long run. And that may mean adding a couple of staff in to provide those specific skill sets and attention to the CHW differently than you may to your other healthcare providers. So with that, I'm going to end and pass it on. Thank you.
Great, thanks so much, Heidi. We'll turn it over to Joe here. Hi, Joe.
Good morning, everybody. So I also, like Heidi, I'm glad to be here. I want to thank you, and I appreciate the invite for, hearing the voice from the field. I started off with community at the center, thinking about exactly what Kathy had briefly spoken about earlier. Is I really appreciate in this report the inclusiveness emphasis on lived experience. Historically, being a returning community member, there's over 40,000 collateral consequences of incarceration, which makes it legal to discriminate against those of us that have been to prison or have a felony record. And in this report, noting and including us was really big, and I think that's going to be big. I, like Heidi, also wanted to look at how HRs around the state will need to be trained. And we're thinking about, not in this case, not just a returning community member, but like incorporating the person in the team. In our model, the community health worker is actually a part of the medical team. Our model has been it's evidence-based, it's been studied. We know what the results are. And the savings are from having a community health worker work in a clinic type setting, building relationships that keep people in continuity of care. And this report has included us, and I really, really appreciate that. When we think about nothing about us without us, seems like seems like common sense. But if sense was common, we can go on and on about how sense just does not seem to be common in the environment we live in today. And on that note, nothing about us without us. If we are not at the table, we are on the menu. You know, I get to consult and teach nationally other community health workers in 14 states and Puerto Rico. And moving forward and doing the work that we do, you know, often policy is developed that affects our communities and investments without having any of us at the table to help define the problem, to help come up with a community-based solution. And I think community health workers, not only in California, but around the nation, should be at those tables. We know our communities, we know the people we serve. Slide, please. When we think about the scope of practice, that's also something that you know, our scope of practice as a community health worker in the clinic or in the form where we work really can't be tied down by certification either. I think a scope of practice should be big. Like in TCN, you know, our basic goal or our elevator pitch is what we do with the people we work with, and the report supports is we work with men and women getting out of prison. We teach them to navigate the medical field. We look at their social determinants, and using motivational interviewing come up with both a reentry plan and both a health plan. Does this differ big from CBOs? In some cases, maybe, in some cases, maybe not. It really depends on the structure of the community-based organization and how they're utilizing community health workers. But this report supports both the community-based organization and the clinical community health worker by allowing us to be a part of, one, the policy, and just to be at the table. Our role, like I said, expands from taking people, hand-holding to appointments, and to being a part of the medical team, both being able to navigate and, what's the correct word? Be the interpreter from the community to the clinic and the clinic to the community. And this report supports that inclusiveness. It supports that scope of practice. Slide, please. And I'm very, very excited about CalAIM. You know, CalAIM does incorporate reentry. You know, I'm hoping that this will, you know, provide, you know, more community health workers in California that will be able to provide those services for those men and women coming home. We know during this pandemic, as it was, you know, earlier briefly addressed, how it affects both our communities and, you know, following San Quentin and some of the other prisons, how it has affected our prisons and, you know, what the cases and what we need, right? What's not really spoken about and what I would like us to think about maybe in the question period is, while I'm excited about CalAIM, we need funding to bridge that year. You know, this year is going to be probably rough on a lot of clinics and the pandemics, and I'm hoping a lot of community health workers that either work in clinics or CBOs are not released because of it. You know, on that note, I thought this report was great. I thought it was thorough. I thought it touched on many areas. I feel like I was heard while I read the report, and I look forward to not only California, but other states following us as we set the stones that will be followed throughout the nation. Thank you.
Great, thanks so much to all of you. If we can all join our screens. Thanks so much, Joe. You know, Carlina and Heidi are coming back on as well. First of all, thank you both, Joe and Heidi, so much for sharing your reactions. I know a handful of minutes is not enough, but we really appreciate your reactions from the field, your call to action, your the areas that you wanted to highlight. We really appreciate that. We're going to turn to some questions, some rapid fire Q&A here. I'm just going to answer a couple just straight off the bat. First, I needed to clarify that community health worker certification is voluntary. Texas, in Texas, voluntary in terms of not being required for employment. Carl Rush here sent me a note clarifying that though Texas technically requires it for paid employment, it hasn't been enforced for over 20 years. It's not being used as an employment, as a milestone for employment. Second, does California have a certification path for community health workers? I thought perhaps, Carlina, you could talk on that one for just a second in terms of the recommendations of the report. And again, this is a certification path for community health workers themselves rather than.
Yeah, Kathy, thanks so much. Great question. California does not have a path for certifying the worker. And probably for those of you in the field, you know, this has been a topic of conversation for many years. And that was really not what came out of the California Future Health Workforce Commission, which I should also mention, there were a lot of community-based organizations involved in authoring that. It was focused on looking at the training entities. But as Kathy said, you know, based on the report and a lot of the findings and a lot of what's happening around the country, certifying training programs is certainly not the only answer. And Heidi pointed out, like, there's thinking about the employers, how the employers are supported, thinking about pathways and pipelines, thinking about, you know, additional career opportunities. So there's a multitude of things that I think can happen to advance this workforce. And so the report touches on a number of them, and the training program piece is just one. I'll say one other thing. I think Jerry typed in a question about, you know, were there CBOs included in the report? And this is a focus on healthcare. Just a reminder, this report did come from the California Future Health Workforce Commission. But that being said, there were a lot of CBOs who were interviewed who don't just work in the healthcare sphere. They touch healthcare, but they do a lot of other things, including really powerful advocacy in their communities. So we did talk to a number of those organizations in some training programs, but it did focus on the intersection of those organizations with healthcare. Thanks, Kathy.
Great, thanks. Another question on the rationale for Washington to offer training but not issue individual training certificates. I believe there was a conversation. Our understanding from talking with Washington is that it was something they considered, but you know, realizing that there are upsides and downsides, they wanted on both paths, certifying or not certifying, they chose to have the robust training, but not issue training certificates to individuals. And you'll see a couple other states have, you know, are certifying programs, as Carlina just mentioned. And so that is another option, but they chose not to make the certification around the individual. The next question is on states that rely on an independent body to certify community health workers. And I think we mentioned South Carolina, who is working, well, both South Carolina and Michigan are using their Community Health Worker Association to some role in terms of being an independent outside body. In Michigan, they're leading the work on training, and in South Carolina, the Community Health Worker Association was working together with the state to develop the Community Health Worker Credentialing Council. So I think those are our two examples that we would hold up there.
Kathy, there's one question I wonder if we could put to maybe a question we could put to Heidi and Joe about integrating folks who are monolingual Spanish speakers into healthcare systems. I wonder, Heidi, if you have anything to say on that one. It came up a couple times in the chat.
Yeah, I think this is really important because I do think, particularly for the clients that we serve who are monolingual themselves, that sort of lends credence, right, to their validity and their importance to have someone advocating for them who is like them. I think one of the challenges often is that if the receiving end of the Promotore work can't figure out how to accommodate them, it makes it very challenging to be effective, unless then you have someone to sort of interpret for you, which introduces another person into the mix. But I think it's doable. And I wish that we were moving towards a state where we could provide services to whomever in whatever language of their choice. And that's ultimately the goal. In the interim, though, I don't think it should inhibit monolingual promotores from working. It just means we have to introduce another person to help with the translation. I know that I personally had a couple of community health workers in Boston who were not fluent in English, and they were still incredibly powerful. We did their internal documentation in Spanish and could provide clinical supervision in Spanish, et cetera, and accommodate them. When they went to the clinic, though, and were working with the front desk staff or the provider, whomever, who didn't accommodate them, it could be very challenging for them to be an advocate. So then we often had to buddy them up with someone else who could provide that accompaniment.
Great. Thanks, Heidi. Well, I realize we're over time, and so just wanted to thank all of you on the line for joining and participating, submitting questions, and especially a big thank you to Heidi and Joe and Carlina for sharing some thoughts throughout this presentation. We really appreciate it, and I hope everyone has a great rest of your day. I should note, oops, I'm not done, sorry. I should note that there will be an evaluation that shows up at the end when you exit the screen, and if you could complete that, we would appreciate it. And lastly, I know we've answered this, but the slides, as well as a link to the report and executive summary of the report, will be sent out after the meeting. Thanks so much and have a great day.